speaker is Dr. RITA Das from Amri Hospital, who is going to talk about the medical management in case of very severe advanced glaucoma. Over to Dr. RITA.
Good morning, everybody. Coming to my topic, recent medical management in advanced glaucoma. I don't have any financial disclosure. In any glaucoma, our main goal is to preserve whatever visual function is there, to keep it, and to maintain the quality of life of the patient. And in advanced glaucoma particularly, this is very important because already the damage is very much. And coming to the recent medical management, lot of newer anti-glaucoma drugs are available, like ROCK inhibitors, netarasudil, latanoprost, prostinbunod, and the combination therapy like latanoprost and netarasudil. That doesn't mean these recent medical drugs available are the first choice of treatment in case of advanced glaucoma. That I want to emphasize. These are the newer drugs available, but these are not the first choice of drug. And in a glaucoma particularly, when there is rapid rate of progression, as in E, or the patient is at a young age, so our treatment modality is aggressive and we want a very low target intraocular pressure, either in lower teens or single digit in higher number. So coming to the consideration of first choice of treatment, where the likelihood of symptomatic vision loss is more, we take into account lot of things when we are considering our medical therapy. What is the advanced initial damage, and what is the rate of progression, and what is the life expectancy of the patient, and additional risk factors like any cardiovascular risk factors, migraine, TIA, and use of steroids or anything like that, or any adverse consequence to intervention. Suppose the patient cannot go for surgery, split fixation is there, and chance of wipeout is more, so we go for medical management. So all these things are to be considered while giving the first choice of treatment. And after considering all these things for and deciding for medical therapy, we set the target IOP according to the patient's status of the disease. And while setting the target intraocular pressure, what I want to emphasize, both the eyes should be considered, because the disease in both the eyes are different. They're not same. And the target intraocular pressure is decided according to the damage in each eye. So both the eyes are considered while deciding the target intraocular pressure. And the patient preference should always be considered while deciding the target intraocular pressure. Coming to the first choice of treatment, how to go about it in a systematic way. First of all, we should see the systemic condition. Any prescription we are giving, we are writing first whether there is any drug allergy or not. So exclude any drug allergy first before deciding for the treatment option. Then one has to ask for any specific disease, systemic disease like asthma or arrhythmia, because we cannot give so many drugs there. And note any concomitant medication he is taking, because if the patient is taking systemic beta blocker, he cannot take the topical beta blocker, it will not be that effective. So systemic condition to be taken into account, and along with the ocular characteristic like ocular diseases and concomitant eye diseases. In the ocular diseases, if the patient has any ocular surface eye disorder, the preservative-free medication should be considered, and if there is a concomitant eye disease, that should be considered before deciding the first line of therapy. So because we cannot reverse back, we cannot go back, so proper history taking and proper examination and proper evaluation of the patient is important before starting the medical therapy. And in the first line of therapy, particularly, usually we consider prostaglandin analogs or prostamides, beta blockers, alpha-2 agonists, and carbonic anhydrase inhibitors. And when choosing the therapy, first line of therapy, from either PG analog, beta blocker, or any of these things, or other modalities also, if it is well tolerated and effective on the intraocular pressure and our target intraocular pressure is achieved, periodic evaluation should be done. And like visual field, optic disc, and intraocular pressure monitoring should be done. If it's stable, the follow-up should be done, and in advanced glaucoma, it should be in a 3 to 4 months interval, because short-term follow-up is required. And if the target IOP is not achieved, the second drug usually added, or if it is not, the first drug is not well tolerated or not effective, the switch the monotherapy or consider other modalities of therapy like laser or surgery without any ego. And if the target IOP is reached, but it's not to our level what we want, then the second drug is added and the target IOP is again monitored. If the target IOP is not reached after adding the second drug, substitute the second drug and verify the efficacy and tolerability. And also you can consider, if you are not comfortable with the second drug efficacy and tolerability, you can consider other therapeutic options like surgery and laser. And long-term, short-term fluctuations while giving any drug in advanced glaucoma is very much important. So that should be always kept in mind, because fluctuation is the very important risk factor for progression. So coming to the target intraocular pressure, there are a lot of definitions for target intraocular pressure. This one is from World Glaucoma Association. Target intraocular pressure is an estimate of the mean intraocular pressure at which the risk of decreased vision-related quality of life due to glaucoma exceeds the risk of treatment. If you don't treat, the risk is more than the risk of treatment. So you have to treat. There is no alternative point. So in advanced glaucoma, it appears to need to decrease the intraocular pressure to less than 14 millimeter mercury, and preferably it should be below 12 millimeter of mercury with minimal fluctuation over time. And for normal tension glaucoma, a fall in intraocular pressure below 30% from baseline has been shown to be significantly reducing progression. And a study from Sehota et al. Has shown when the intraocular pressure is below 12 millimeter of mercury, the progression rate is only 2.3%. And coming to the patient approach, actually it's an advanced disease, so quality of life, everybody has told it's very much affected. So it should be treated in a holistic approach, that is a bio-psycho-socio-spiritual profile of each patient should be taken into account, and the patient should be treated very carefully, and it should be a team effort. And patient care personality, their relatives, they should be well informed and they should be taken into the team, and the patient should be treated in a very careful manner so that the quality of life would be should not be impaired. So patient characteristic like his clinical picture, systemic condition like any systemic or ocular condition is there or not, particularly adherence of the patient, which is very important, and quality of the life should be taken into account when patient characteristic is considered for first choice of treatment. And along with the drug properties, which is also important, mechanism of action, because when we are combining two drugs, there should not be same mechanism of action, because the effect will not be that much of additive. And efficacy of target IOP and unpreserved drugs should be considered, along with the cost, which is not the least important factor, because they are elderly patients. So to conclude my talk, monotherapy is the first choice when initiating therapy. Baseline IOP should be considered while evaluating therapy. Fixed combination are not first-line medication to be considered where individual intraocular pressure targets with monotherapy fails. Prescribing more than 2 bottles of intraocular pressure lowering drops to be avoided, as it may affect compliance. In case of ocular surface disorder, preservative-free combination to be considered. Generic drops can differ from brand drops and should be monitored more closely after switching to generic drops. And during pregnancy, In young patients, potential risk of continuing anti-glaucoma medication to the fetus to be balanced against the vision loss in mother. Thank you for your kind attention.
Thank you. Thank you very much, Dr. Rita. In a very short time, you have practically covered all the aspects of medical management. I'll just tell you some of the carry-home messages. But in advanced glaucoma cases, don't give a medication which will cause low blood pressure. So that will worsen the situation. Second, the monitoring of the treatment of hypertension, which most of these patients suffer from, have to be really, really carefully done, because a nocturnal dip with antihypertensive medication is likely to worsen the situation. Don't use a medication, glaucoma medication, locally, which is likely to damage the macula, CME, chronic macular edema. That will take away the central vision, for which the glaucoma is totally, the advanced glaucoma patient is totally dependent on. So he's already lost the peripheral vision, and you are using the medication without realizing that you are also damaging the central vision. You are causing more harm than doing any good to the patient. Now, you have to choose a medication which has multiple actions. It has got, increasing outflow, decreasing production, increasing vascularity or vascular supply, or neuroprotective action. The Rho kinase inhibitors is meant for all these purposes, and it is likely that this medicine with a modified form, I don't think the presently available Rho kinase inhibitors, which are known to cause the low blood pressure, it will increase the scleral, they decrease the scleral resistance, episcleral venous pressure, and it also provides the nutrition to the ganglion cells and protects the neural cells, also increases the vascular supply in the optic nerve head. But we do not know whether this is really doing the job, and we may have to use it for longer time and expect a newer medicine to come up to serve this expectation of ours.